Did you know that heart disease is the #1 cause of death among women in the United States? And that heart attacks in women may present with different symptoms than heart attacks in men? Women and men have different and often very specific healthcare needs. Our guest on this week's Health Talk will explain why women's health is different and is so important. So please stay tuned. Health Talk is up next. Hello, I'm Dr. Eric Mazer. Today we're going to talk about women's health. My guest is Katelyn Scott. She's an advanced practice registered nurse with Nuvance Health, Women's Health. Among Katelyn's interests is women's health.
Yep, it is.
In primary care. Well, Katelyn, welcome to Health Talk.
Thank you. It's nice to be here.
So you're an APRN, and I think a lot of, let's just start from the beginning. You were not always an APRN. I know that you were doing nursing at Dana-Farber.
I was, yeah. My background is in oncology. I worked as a nurse in oncology for about 5 years, and then I just started working as an APRN this past year.
And did you have to do additional training to be an APRN?
Yes, I did. So I went back to school for an additional 3 years. I was able to continue working as a nurse throughout that time so I can keep up my skills. And I did clinical rotations in various specialties to get a taste of what I was interested in, what I really liked to do. And at the end of my program, primary care was what I decided was my main focus.
So what made you decide to move from nursing to advanced practice nursing?
To be honest, it was something that I always felt like I wanted to do. As a nurse, I loved being a nurse. When you're a nurse, I believe it really does stay with you forever. But that's something that I love about being an APRN. It's what makes you unique, and what separates you from other providers is that you have a unique relationship with the patient, because you kind of learn that as a nurse. You learn what patients can connect with and can relate to most. And I just feel like it allows you to have a special type of relationship with patients.
And tell us a little bit about, you're doing primary care now. That's very different than doing oncology nursing.
It is very different, yeah.
Although I think one thing that must be similar, I practiced oncology, as you may know, for many years, and worked side by side with APRNs and regular nurses, or I guess I don't know what else to call them.
Right.
But medicine is a team approach. It's a team effort today. So
Absolutely.
Tell us, how you just came here to Nuvance Health in Norwalk and are opening a practice.
We are,
Tell us a little bit about how does that practice work? How do you fit into that practice?
Sure. So we just opened up a practice called Norwalk West Primary Care about a month ago. And it's myself and 2 physicians, and we all work together. We all have our own patient panel, our own patient volume, and we actually, our responsibilities are essentially the same. We have a nurse, and we have 2 MAs, and
those are medical assistants.
Medical assistants, yes, and we all work together very, very closely. And the front staff as well, they're the ones that book the patients and things like that.
So a patient who might be interested in your care would call and ask to
and they could
see
request,
Katelyn Scott.
Exactly, they can request me as their PCP just the same way they would a physician.
And I'm sure having the physicians there allows you then to have them as a resource if you ever reach something which you need.
Exactly, so we can bounce off ideas. I can go to them and say, hey, what would you do in this scenario with this patient, this situation? What are your thoughts on this rash? Or, and we can kind of work together. Even though, I have my own set of patients and they have their own set of patients, we still can co-manage.
Which is, I think, the way best medicine is practiced, because none of us knows everything, and it's 2 minds are always better than one.
Exactly. So
after being in oncology, which is so intense, tell us about your interest in primary care.
Sure, that's a really good question. So my experience in primary care was wonderful. I feel really lucky that I had that experience working as a nurse. But through that experience is what made me decide that I wanted to work in primary care and work in disease prevention and health promotion. Because, once you get to a patient, once they have cancer, you have options, but sometimes you're limited. Whereas I wanted to be able to work with the patient before they have those issues and help provide the best possible care to prevent them from developing these chronic illnesses or cancer-related issues.
Now, we talked about at the introduction that your interest is women's health.
Yeah.
So are all your patients women?
Oh, no.
So you will see men?
Yeah, so actually our practice is family medicine, so we see patients from 0 to 100 or beyond 100, men and women. And so I have a special interest in women's health. I'm a woman, and I feel like I can relate to women in that type of care, but no, we provide care. I could provide care to men. Actually, I would say over half of my patients right now are men, but women's health is something that I am interested in.
Now, for many years, I think women's health was almost secondarily dealt with. I don't like the construction, but it was almost an aside of the medical establishment. And I think we finally have learned that women's needs may be different, certainly emotional needs may be different, but even the illnesses are expressed differently in men and women.
Absolutely.
What do you think are the big issues that you see as a women's health expert in primary care?
Sure. Well, one thing that comes to mind right off the bat is heart attacks, MIs. We always think about men with heart attacks, but interestingly enough, women are just as likely to have a heart attack as men, but not everyone knows that. And not only that, the heart attacks might present a little differently in women. We are more often going to see an atypical presentation in a woman versus a man. That's not to say they're not going to have chest pain. They definitely can, but a lot of the time you might see more epigastric pain, more fatigue, more dizziness, maybe even nausea, maybe no chest pain. So educating my patients.
This is so important too, because again, I was taught, and which was preceded our understanding of women's health, that heart attack symptoms of an elephant sitting on your chest, pain running down your right arm, maybe short of breath, some a little lightheaded.
Right.
But we were always looking for that chest pressure. And when you say women present atypically, they typically for women, but atypically as a man.
Exactly.
In other words, their symptoms may be more GI.
Yes, and actually that's more common to see GI symptoms in women. I mean, men can have GI symptoms as well, but you don't always have chest pain, and that's the most common symptom people associate.
So this is important for women to know too, because heart attacks are treatable in this day and age.
Exactly. So a big part of my job, which I love, is educating my patients on this so that they know the warning signs, they know when they need to seek out emergent care. And that's something that I've found over the years that patients, they don't know. And so that's our job as healthcare providers, is to teach them this, to keep them safe and healthy.
Now, women, do they worry about their cholesterol as much as men do?
They
should.
They should. Yeah, exactly. But they don't. They don't always think about their cholesterol because, again, when you think about high cholesterol, strokes, and things like that, we often think more of that in men. But women are, again, just as likely, just as at risk, and their cholesterol management is very important, especially postmenopausal. We see changes.
I was going to make that point. Go ahead.
Yeah, so postmenopausally, your hormones change after women go through menopause. So they become more at risk for MIs, they become more at risk for strokes and things like that. So that maybe is part of why, for a while there was that confusion over why women their health is different than men, and why we look at it a little bit differently.
Women are protected for cardiovascular disease
with the estrogen.
For that first 50 years of estrogen,
exactly.
But then they rapidly catch up after their estrogen diminishes post-menopause, and a lot of women don't know that.
Exactly.
And again, heart attacks, this is a different era for heart attacks than it was 25 years ago. We can stop them in the middle, and we can prevent them with my own family. My dad had a heart attack before 60.
Oh, wow.
And I have high cholesterol. I've been on a statin for 30 years.
Well,
and I have zero heart disease.
Yeah, and that's how it should be.
And it's been prevented.
Exactly, and that is the goal. That is the ultimate goal, is to prevent these diseases, because we know they're preventable if managed correctly. That kind of brings me to another topic of cervical cancer. Cervical cancer is the only cancer that is 100% known, the cause, HPV, the virus.
Yeah, we say that again because I don't think people realize that. This is a virally caused cancer.
Yep.
And that virus is spread by sexual activity.
Correct.
We know that.
We know that. So people think about lung cancer and they say, oh, smoking causes lung cancer. Well, yes, smoking can cause lung cancer, but other things can cause lung cancer as well. Whereas cervical cancer, HPV is the only cause. So with that knowledge, we have the ability to, in theory, prevent this disease through vaccination and through testing.
So if you ask the public, go out there to the public, and we say, would you like to get a vaccine that prevents cancer? I'm sure everybody would be knocking down their doors. And yet, it's been a tough road to hoe, hasn't it?
Yeah.
Why the resistance? Well, I guess because it's mixed up with sexual mores.
So,
but talk about that a little bit.
Sure. So that's actually what I was going to say. A lot of the time I see hesitation from not even always the patient, but from a patient's parent. A teenage patient who's eligible and is due for their HPV vaccine, and then the parent says, oh no, but my child isn't having sex, there's no reason for them to get this vaccine. or maybe this is going to condone them having sex, and that's a very common misconception, because the purpose of the vaccine is to prevent cancer down the line in their life, not in that moment. So,
and once you acquire the virus, the vaccine doesn't work or is not as effective?
So no, the vaccine, you can give the vaccine up until age 26. If you've already acquired the virus, you should still be vaccinated, because the vaccine is only preventable against certain strains of HPV, and we don't always know what strain you have.
And it's not all the strains, as you said, but several strains, the most common
The most
strains.
common, and typically it's the most cancerous causing strains. So we know HPV 16 and 18, those are ones that we...
And a lot of people will get those viruses and cure themselves and they're fine.
Right.
But the problem is that there's a subset of people, those viruses will live forever.
Right.
And they can cause cancer.
So we actually have found that, like, I think it's over 70% of the maybe even more than that of the population has HPV at some point in their lifetime. Most of the time they don't know. Men as well. So there's actually no way to test for HPV in men through blood work. Women, obviously, they have cervixes, so we test through their cervix. You can't do that with men, but we know that men do get HPV because they spread it to their partners. Women. But not only they infect women, they themselves are at risk for cancer. My background with oncology, I used to work with head and neck oncology patients, and interestingly enough, we would have a lot more men than women with this head and neck cancer. And HPV, it was one of the very common causes of this cancer in squamous cell head and neck cancer. So, you know, when you're thinking about the vaccine and you're thinking about whether or not you should have your child vaccinated, think about their whole life, and think about all the people that they could potentially be spreading it to, but themselves as well. It's for their own protection from cancer.
We're vaccinating boys as well, aren't we?
Yes. Oh, yes, we are.
What are the recommendations for what age do they?
So around age 10 to 12 is when you can start. Same for girls. And you know, I think the boys being vaccinated has been a slower progression. We're seeing more women, more girls getting vaccinated, but you know, unfortunately, not all men, not all boys are. And that's something that really we need to spread more awareness to. It's equally as important for men to be vaccinated against HPV as it is women, in my opinion.
Yeah, and I think, you know, we have less than a minute left, so let's just take this time to hammer home this point.
Sure.
You can save the life of your child or their spouse or girlfriend or boyfriend.
Exactly.
By having them vaccinated when they're appropriate. This is, HPV stands for human papillomavirus.
Correct.
There are a variety, I think there are a variety of numbers. The vaccine doesn't cover all of them, but it covers the most oncogenic.
Right.
And this is a way to save lives.
It is. That's what it comes down to.
And it's a simple I don't even know if are there side effects of the HPV vaccine?
You know, it's just like other vaccines, very few side effects. You know, maybe arm soreness, that's...
Well, that's...
But no, there's nothing extra, you know, beyond your
So there's
regular...
really no reason not to do this, and we can save lives. This is medical, this is a wonderful medical
It's incredible
technology.
if you really think about it.
It's a vaccine that prevents cancer.
It's a vaccine that prevents cancer. It's one of the only vaccines we have that prevents cancer.
And you know, I've seen advanced cervical cancer when I was practicing oncology. It's an ugly disease. It's a terrible disease.
Very ugly.
And people suffer.
Yeah, and it's 100% preventable at the end of the day. So.
So please get your HPV vaccine,
yep.
or have your kids get it.
Exactly.
Unfortunately, we have run out of time. I really want to thank my guest, APRN Katelyn Scott, for joining me on Health Talk today. And thank you for watching. Please share your questions and comments with us at healthtalk@newvancehealth.org.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. I'm coming back. Ask your doctor, check your blood pressure.
We've all heard the saying that an ounce of prevention is worth a pound of cure. This is all the more true in healthcare, where we've learned that preventive medicine reduces patient suffering, it saves lives, and it even saves money. Illness prevention and early detection are the principal goals of primary care medicine. Our guest on this week's Health Talk will discuss the importance of prevention promotion, so please stay tuned. Health Talk is up next. Hello, I'm Dr. Eric Mazer. Today we're going to talk about preventive medicine. My guest is Katelyn Scott. She's an advanced practice registered nurse with Nuvance Health. Preventive medicine is a major focus of Katelyn's practice. Katelyn, I know you came to APRN-ism because you wanted to do, because you like primary care.
Yeah.
And primary care is all about prevention and early intervention.
Exactly.
What do you think are the biggest things that we're missing today?
In terms of primary care?
Yeah.
So
in terms of preventive medicine and primary care.
Sure. You know, one thing that comes to mind right off the bat, especially what I've seen, you know, recently with the COVID pandemic, mental health is something that we're seeing a ton of right now, especially in primary care. And, you know, depression, anxiety, and, you know, everyone around us has had a challenging year. So, but even before the pandemic, this was something that was very relevant, but yet not discussed often. And patients, some of them I've found don't realize that this is something they can talk to their provider about.
And something that can be done about it.
Exactly. Yeah. So, you know.
Let's talk about depression or anxiety a little bit.
Sure.
Everybody is depressed sometimes. Everybody is anxious sometimes. When should someone begin to worry about it?
That's a great question. Typically, what I tell my patients, when these symptoms are interfering with their lifestyle, their daily life. So, you know, you had a bad day at work. You know, even you had a loss. You had a loss in the family. There are certain times where it's very appropriate for you to be feeling depressed, but you know. I guess with grief, it's a little bit more complicated. There are certain periods of time that if it's been going on for, you know, longer than a certain amount of time, it's not, that's concerning. But in a regular person, if you are anxious over a test or you're anxious over, you know,
Going on a TV show.
That's appropriate. But, and there's different types of anxiety. There's situational anxiety and situational depression, but there's also times where it's, you know, more of a chemical imbalance, and it's with that person, regardless of the circumstances in their life. So identifying if there's something going on in their life, can we make a change? Can we do something about it before we need to look to medication management? That's one part of it. But then if we see, okay, we've tried these things, we've tried other ways to manage your symptoms, and you're just not feeling any better, that's when we know we really need to do something about it.
Now, I've been doing the show for decades, and whenever we talk about psychological disease, the answer is always the same. When it begins to interfere with your everyday life, then it goes from normal to abnormal. And of course, as you said, if you're grieving a loss of a loved one, that's going to interfere with your life for a longer period of time.
Right.
But there are limits to that too.
Exactly.
Why is this a primary care problem?
Well, you know, it's a primary care problem because mental health affects your physical health. So you're highly anxious and you're not eating and you're not sleeping right, you're not taking good care of yourself, you're missing appointments, you're not taking your medications, you don't have any motivation to get out of bed. This all affects your physical health. You know, you're at higher risk for heart disease even. All kinds of things from when your mental health is not well. Another reason we see it a lot in primary care is just because there's not enough providers out there in the community to treat mental illness. So it does come, you know, we do see it in primary care more so for that reason.
I wonder too if there still is a stigma attached to mental disorders, mental health.
And there is.
I think people will be much less reluctant to discuss these problems with their primary care provider than they might be with a psychiatrist. I think the activation energy to go seek help from a psychiatrist or a psychologist is a lot higher than to mention it to your primary care.
Right, they're already there for their physical, or they're there to get their blood pressure checked, and it's not always something that a patient is ready to disclose right off the bat. Sometimes it takes a little bit of digging and discussing it with the patient. Other times they may just be feeling so unwell they just burst into tears, and they it's very clear that they need to be addressed. It needs to be addressed that day.
I've actually seen some people postulate that primary care providers should screen for depression on a regular basis. Do you have any thoughts about that?
Oh, absolutely. I mean, we do actually. As a matter of fact, you do the PHQ screening for their physicals and things like that, and then depending on how they score that, then there may be another assessment that we prompts to do another screening.
So that's a quick questionnaire?
It's like 2 questions, and then 2 or 3 questions, and depending on how they answer that, it may prompt doing a further screening with more questions, a little more involvement. But yeah, I mean, I think identifying it in primary care is key, because we're the ones to see the patient, face to face. We're the ones that have the most regular interactions with them, and so it's appropriate. It's absolutely appropriate.
My understanding also is that primary care providers are trained to treat depression. Again,
we are
at the say simplest level, but at the more common levels of depression, anxiety.
Sure. So if somebody has standard unipolar depression or standard generalized anxiety disorder, it's absolutely appropriate to be managed in primary care. It's only when it becomes a little bit more complex and they're on more than 1 or 2 psychiatric medications that then we would probably want to consider a psychiatric referral.
Do you do any counseling therapy as a primary care doc?
So, in our visits, we do, I personally do counseling with my patients, but we also have a social worker in our office that we refer patients to, because having a dedicated counselor that you can meet with on a weekly or every other week basis is a huge component of managing mental health. And, medication, there's absolutely a place for medication, but having a conversation with a therapist, having someone that you can talk to on a regular basis, that's just as important, I believe.
Well, my understanding is that I agree entirely from my perspective that medications work so much, counseling works about the same alone.
Right.
But you put them together and you get more than either of the separate. And this is common, isn't it? It's maybe you could even talk a little bit about the difference. Here's where I think men fall down, because I think men, I don't know if it's still as true as it used to be, men tend to want to be macho, not admit that they are suffering mentally, emotionally.
Yeah.
Women tend to be a little bit more open about these things. Could you say a little bit more, convincing people they should speak up?
Sure. So I mean, that's absolutely true. Women they do tend to be more forthcoming, and whether it's because they, I think a lot of it boils down to biology. Women, that's just kind of where it's easier for women to talk to one another and open up about their feelings. Whereas men, they feel like they have to be this big macho strong person, and they feel like it's a weakness if they do say they're feeling sad or they're feeling anxious. And what I tell my patients is that's just not true. The fact that you're able to say you're not feeling okay, that something's wrong, that makes, in my opinion, that makes you even stronger, because it is hard to do. So I try to praise my patients when they do disclose these things to me, because it's the first step to getting better. So, but yeah, so men, I mean, I'm a huge advocate. I feel like with my patients, I have to press them a little harder, but when men do have depression and anxiety, eventually, I can get them to talk about it. But it's not as easy as women, that's for sure.
And it's so important to realize that depression or anxiety, first of all, it's really common out there.
It's extremely common.
I'm sure COVID has made it worse. Maybe you could even say a few words about that.
Yeah. I would say over half in the past year, maybe 80% of the visits we've seen have been mental health related. That's kind of a random number, but in my experience.
But it's been such an artificial situation, difficult situation. You're trapped at home. You may have a wonderful relationship with your significant other,
Right.
but that not necessarily, you still are going to trip all over each other.
Right.
You're with the kids, you can't send them off
There's
to
just
school.
been so much uncertainty.
And
people
that's
losing their
before
jobs.
anybody gets sick.
People losing their jobs, or
Financial.
or they're working from home, but they're just being in that environment of working from home and not having that same social stimulation. That alone can cause people to feel isolated, or to feel depressed, or to feel discouraged. So there's a number of reasons. But then we also see patients post-COVID having this anxiety and depression state. I had a patient just the other day who was a long-haul COVID patient. She's had symptoms for 3 or 4 months, and she hasn't, there's certain things that just haven't gotten better. And she just said, no one believes me because no one thinks this is real. Why am I still sick? It's been 4 months. And that's causing her significant mental distress. I think that's one of her biggest complaints, is how she feels mentally.
Yeah, COVID has taken an enormous toll in so many ways, but this is so mental health. That's we're spending a lot of time on that, but I think maybe because we don't always think about that
Right.
in primary care or in primary prevention. And just let me say also, the drugs are great.
Yeah.
The drugs are great.
SSRIs, yeah, no, they work. And that's the best part, I think, is when I am able to sit and have a real conversation with somebody about it, and we do talk about medication, and once they're comfortable and they're agreeable to it, I see them back in a month and they're like, why did I do this sooner? Why did I wait so long? And the side effects we can manage the side effects, we can manage the symptoms, and most of the time my patients say, why didn't I do it sooner?
Yeah.
that's the response I see.
And again, the hardest thing is we just have to overcome some of the stigma. And I think
Exactly.
slowly it's happening, but mental health is it's an illness, a treatable illness like pneumococcal pneumonia. And
Exactly.
we have to begin
Exactly.
to understand, not a weakness.
We have to look at it more like that.
We've got less than 2 minutes left, and we talked a lot about mental health prevention. What are some of the other big things you want to emphasize? We had talked at a different time about
Sure.
cholesterol in women. I think that's another good one to emphasize.
Sure,
Go ahead.
sure. So you want me to talk about
You
the
go on,
cholesterol?
whatever you want,
Sure.
but I think that's one that's important.
Yeah, sure. So, we check, I check my patient's cholesterol starting, you really can start up as young as age 18, but, as we get older, it's even more important. And diet and exercise, that's key. I mean, we know that, we say that, but actually going out and doing it, that's the hard part. That's the hard work. So, and women, especially, like we said, postmenopausal women, they find it harder to lose weight. They find it harder to, their body is changing. So they have to adapt to this new way of their body. And we see it reflective in their blood work, in their cholesterol, in their weight, in their BMI, and things like that. So I think that's what makes it different for women than it does for men, is that they have a change, whereas men, it's kind of consistent throughout their life, So
You can have trouble losing weight your whole life, like me, instead of just after 50.
yeah, so that's might be part of it. But another thing is smoking cessation. I see a lot of patients that come in and maybe they're not ready that day, but they're motivated. So we assess how ready they are to quit. And we, again, we see this, you think more about this with men, but it's women too, Sometimes women have an even harder time to quit.
Yeah,
because
I thought the numbers were worse for women in terms
they
of
are.
discontinuation.
They are. And so, we have medications, we have nicotine patches, we have, therapy, we have a ton of strategies, but unfortunately the way that the cigarettes are developed nowadays is so addictive that I've had, it's been compared to being as hard to quit as heroin. I mean, it sounds crazy to say that because here cigarettes they're legal. They're something that you can buy in the, over the counter, but they're just as deadly.
Yeah,
and
hopefully kids at home don't start.
Just don't
please
do
don't
it.
start.
Just don't do it. It's not worth it. And but so my job is to educate my patients if they do start and if they do develop the habit, and then to try to assess how ready they are to quit. And if they are, we make a plan and we go from there.
And there's so many other things that we've run out of time to talk about, like blood pressure, diabetes, et cetera.
There's so much. There's so much.
And I keep running out of time. It's really a shame. I want to thank my guest today, APRN Katelyn Scott, for joining me on Health Talk, and thank you for watching. Please share your questions and comments with us at healthtalk@newvancehealth.org. You all take care. Bye-bye.